Really
Very nice.
easy to use. Infographics, you know how many has heard.
The graphic designer in my
No, I'm just messing. Yeah, I think we all heard this presentation maybe at SNFM. So feel free to jump in with your insights. We're just gonna talk about the Dr. Tita study that was published in the New England Journal of Medicine last month, called Azythromycin to prevent sepsis or death in women planning a vaginal birth. And so the rationale for doing the study was that maternal infections during the peripartum period account for about 10% of maternal deaths worldwide. It's one of the three causes of maternal death, the top three causes of maternal death worldwide, including cardiovascular disease and hypertensive disorders of pregnancy. However, while the proportion of deaths related to cardiovascular disease and hypertensive disorders has either decreased or stayed stable, the proportion of deaths related to infection has increased in the past 20-30 years. And the neonatal sepsis accounts for 16% of neonatal deaths, and it's the third most common cause of neonatal death. And so there was two previous studies, one that we results kind of employed here is that there's an RCT of IV azithromycin during C-section that was published a couple of years ago versus standard of care, which is just normal ANSEF, and they showed a 50% decrease in infection rates and lower hospital-related costs in the IV azithromycin group. And then there was a smaller RCT that was done in Gambia that looked at PO azithromycin 2 grams during labor. And in that study, they found that it did reduce maternal and neonatal infection. So based off of that, all of that information, they designed the A+ study, which stands for Azithromycin Prevention in Labor Use Study. Did you think of your name yet?
Moti. I'm kidding. Yeah.
And so they wanted to see if a single oral dose of azithromycin in women in labor planning a vaginal delivery would reduce maternal sepsis or death, along with stillbirth and neonatal sepsis. So their study population was a multi-country, double-blind, placebo-controlled randomized control trial. It was done at 8 sites in 7 low or middle-income countries, so in Africa and Asia, that were part of the global network for Women and Children's Health, part of the NICHD. They targeted pregnant women admitted for spontaneous or induced vaginal delivery. They included single and multiple gestations who were at least 28 weeks, and then they excluded women with an active infection or already requiring antibiotics, excluding just GBS positive. So if they had pneumonia or pilo or something, women who had a known arrhythmia or cardiomyopathy, someone who had an allergy to azithromycin or other macrolides, or if they had gotten a macrolide or azithro in the past 3 days, if they were planning for a C-section before immunization, or if they were in advanced labor, which they defined as more than 6 centimeters dilated. And so they did predetermined 1-to-1 randomization and stratified by site, so of all the 7 sites. And then they did permuted block randomization with varied block sizes. The trial packs of azithro and placebo were numbered sequentially with a computer algorithm and were identical in appearance. And then they basically allocated half the patients to azithromycin. They got a single one-time dose of 2 grams, which was 4 500 milligram tablets. And then the other half were allocated to placebo, which got 4 identical placebo tablets. And then they identified outcomes before discharge, during postpartum visits on days 3, 7, and 42, and then during other visits or telephone calls that occurred on days 14 and 28. And then their research team did a records review of all of their kind of healthcare through day 42, so 6 weeks postpartum, to see if there's any relevant outcomes. And they had many outcomes. Their primary was, they had 2 primary, 1 maternal, 1 neonatal. So the maternal was a composite of maternal sepsis or death within 6 weeks after delivery. And then the neonatal was stillbirth or neonatal death or sepsis within 4 weeks of delivery. And then they had a bunch of secondary maternal outcomes. They looked at the individual components of the primary outcome individually, and they looked at specific infections, so chorio, endometritis, wound infections, which were C-section infections or perineal infections, breast abscesses, pneumonia, and pyelonephritis. They looked at if there was any effect on like the need for therapeutic use of antibiotics later on, the duration of their hospital stay, if they were readmitted, if they had to be admitted to a specialty care unit like the ICU, and if they had any unscheduled healthcare visits beyond those scheduled postpartum visits. And then in terms of their secondary neonatal outcomes, again, all of the individual components of the primary outcome, any sort of other neonatal infection, duration of hospital stay, readmission, admission to the NICU, or unscheduled healthcare visits. And then they looked at safety outcomes, which were adverse events, which are primarily side effects or people who develop allergies to the medication. They said they looked at results of bacterial growth and like blood cultures, and then antimicrobial resistance from these cultures. And then so their analysis, they estimated that they would need a sample size of 34,000 patients to provide 90% power to detect a difference of 20% in the maternal primary outcome. And this was based off a baseline incidence of sepsis and maternal death of 3% across all sites. They use a two-sided.
Their actual incidence is quite a bit lower than that.
Yeah, they use a two-sided alpha and like hypothesize a loss of follow-up rate of like 2 to 3%. And then they also wanted to power to detect a 25% difference in the neonatal primary outcome with the baseline incidence of 8% at their sites. And it was an intent to treat analysis. So whatever group they were randomized to is where they stayed for the analysis. And they used generalized linear models after adjusting for trial sites. They did do an interim analysis with the Bonferroni correction, which Dr. Rigel explained to me is like they basically said if the study was futile or it's right here. The study was futile or like efficacious, and they would stop the study if it was both of their primary outcomes were found to be significant at the interim analysis, or if there was like no difference at all. And they used the level for significance was 0.001 at the interim analysis, and then they adjusted their final significant p-value to 0.04992 to correct for this. And then they did doing a post hoc analysis using cutting their initial alpha in half because they were doing 2 primary outcomes. And then they had several pre-specified secondary analyses. So they did a subgroup analysis looking at regions, so Africa versus Asia, presence or absence of a high-risk infection, subgroup analyses of the primary outcome according to like prophylactic antibiotic use and mode of delivery. And then they looked at potential effect modifiers like gestational type of labor. And then they had an exploratory analysis of looking at an alternate definition for being at high risk for infection as assessed before delivery rather than at randomization. So they screened 44,000 patients between September 2020 and August 2022. About 30,000 underwent randomization, 14,600 to the Azythromycin group, and then 14,700 to the placebo group. The most common reasons for exclusion were if they were advanced labor, so dilated more than 6 centimeters, or if they had a planned cesarean section. And this is their table 1. The 2 groups were similar across all of their baseline characteristics. The one thing they noted is the majority of their patients came from Asia, so about 55%, and about 43% were prime patients. And about 18% were being induced. And both groups were similar across of their high risk for infection or high risk for sepsis, and they defined that as prolonged labor for more than 18 hours or prolonged labor for more than 8 hours. And then this is their primary outcomes. So they found
gestational age, did they have that in the
they just put it here. Birth.
but they only had just okay.
They didn't put the mean.
The average gestational age. There were, I mean, there were 88% term, I guess. Okay.
These are primary outcomes. The maternal death or sepsis rate, the nursing group was 6% and 2.4% in the placebo group, and it was statistically different with a p-value of less than 0.001. This was primarily driven by the sepsis rate, which was 1.5% in the Azythro group and 2.3% in the placebo group. I guess thankfully the death rate was very, very rare in both groups. And then when looking at the neonatal outcome, both groups had about a 10.5% risk of stillbirth, neonatal death, or sepsis within 4 weeks, and those two were not statistically different. And then when looking at the individual components of that composite outcome, they were not different as well. And then they did kind of some subgroup analyses. The one that they highlighted was that by geographic region, the azithromycin can be more beneficial to the patients in the African study sites. The rate of the maternal outcome was like 1.4%. The azithromycin group in Africa versus 3.1% in the placebo group. They didn't see a difference in the primary maternal outcome when we just at Asia. And then it was more beneficial again in patients who underwent spontaneous labor, so the rate of sepsis or maternal death was 1.3% in the Azythro group and only 2.1% in the placebo group, and there's no difference when looking at their like induced as well as when looking at like preterm delivery. And then looking at their secondary analyses, when they looked specifically at different infection types, women in the Azythro group were less likely to have endometritis, as well as wound infections, both cesarean and perineal. I think that was the big thing. And then there's again no difference in their neonatal outcomes.
It's really strange how low their choreo rates were.
It's weird.
You know if it was based off of placental pathology or
Just clinical criteria, yeah. And then
makes you think that they didn't look for it, because that's impossible.
Yeah.
Most were spontaneous labors, I mean.
Also, I mean, by their sepsis criteria, many women would automatically have hit that.
and they did show a lower readmission rate too.
And treating for choreo wasn't an exclusion,
No,
because it was an exclusion prior to labor.
yeah, so if they had an infection, like an active infection at the time of incubation, they would be excluded. But so like these patients all got like GBS prophylaxis, if that was standard practice, they got
Right.
choreo endometritis antibiotics, if those things developed.
it's like only 13 of them would have been treated for choreo.
Like that makes no sense.
Choreo was excluded before they.
I mean, if you don't develop choreo during, I mean, if you don't test anyone's temperature, you're not gonna diagnose.
Well, I think
choreo
it's weird
clinically.
because like their
That's not their sepsis outcomes.
like they had this many people, they had like 600, whatever, 1,300 patients who had like prolonged labor and 1,300 patients who had like who were ruptured for a long time. You would think more than like 11 of them
Yeah.
developed choreo. I don't know what our choreo rate is in these like extended labor patients, but it's much higher than 0.1%.
All of which is to say, like, there probably is a lot of undiagnosed choreo in this population, which we would they weren't getting the antibiotics that we would give them for choreo, which means we might see a dilution of the benefit of Azythro. Right. I just wonder if the choreo, okay, because they didn't see as much of a benefit in the Asian studies. I wonder if all of these choreos were from the Asian sites or not.
It's not really notable in the secondary analyses. So they basically concluded that Azythro prophylaxis led to significantly lower frequency of maternal sepsis or death compared to placebo. And women who were planning a vaginal delivery, they didn't see any difference in their neonatal outcome. Thankfully, maternal death was rare in both groups. And they obviously the death, again, because it was rare, there was no difference between the two groups. So it was primarily driven by decreased rate of maternal sepsis in the intervention group. They did see lower rates of endometritis, wound infections, and maternal readmission. And then they calculated that the number needed to treat, so number of women who needed the one-time dose of Azythro to prevent one maternal death or sepsis was 125. And so their study was obviously the large sample size and the very quick way that they recruited everyone in a diverse patient population that was worldwide, the double-blinded nature. And then the patients who were included were representative of the general populations where the study was conducted at the different sites. Some of their limitations was their lower actual rate of sepsis in the Asian group, so they'd hypothesized it to be 3%. It was only about 2%, so this limited the statistical power for that subgroup. The use of prophylactic antibiotics was high in certain study sites, so they were saying that like in some of the African sites, there's been like a big push to start doing like GBS testing, which is not necessarily standard practice there. And so it's I think one of the sites, I don't remember where it was, they were trying to give patients more likely to get like penicillin in labor, so that may have blunted the effect of the intervention. Azythro, they said is like good for prophylaxis because it has like broad coverage and it primarily covers for bacteria that are not covered by other antibiotics like ureaplasma and mycoplasma. They didn't evaluate cultures for these specific microorganisms to see like it was effective at reducing those particular organisms. And then it was obviously conducted in primarily low and middle income countries. So there's limited generalizability. I know when Dr. Roman and I were talking about it on like Monday or Tuesday, she was asking if like, because I think the residents had presented this at their journal club. And so they were saying like, she was asking if like it's changed practice here. And I think it shouldn't necessarily change practice for us just because we want to diagnose choreo, we do a lot more cultures and things like that. So it may not be as applicable to higher resource or higher income countries. And then just thinking about future research, they're obviously with more antibiotic use, as particularly for prophylaxis or maybe more antibiotic resistance. So seeing what the effect of this would be, and then seeing how this sort of study would function and what the results would be in a higher resource country.
Did they look at
Wait,
HIV
just-
status as well?
Yeah. Or actually, I didn't look at the supplementary tables, but let me.
Just to clarify, we're saying that because I think I was hearing the outcome of sepsis based on their criteria, whether it included a fever and tachycardia, was after delivery, correct? I thought it was. Because primary or composite, it was after delivery. Meaning, just if a patient had an intrapartum temperature and tachycardia, was that defined as sepsis in this study? I don't think,
It was
meaning,
like
are we?
within 6
It's
weeks.
usually from randomization to
Yeah.
whatever they
So that's
talk
6
about.
weeks.
You know, the moment you get randomized, usually
Then
you.
I'm thinking, then I can understand why we're saying, oh, maybe it's actually because obviously death was different, but the sepsis was different, then are we just preventing choreo? If
Right.
one of those,
And I think the argument becomes, is a maternal fever and a heart rate, is that sepsis? And I would argue, no. Like,
after delivery.
it depends, it all depends on how you define sepsis.
I mean, they were defining sepsis as involving one or more signs of organ dysfunction.
Yeah, but the
Right,
two
it's
primary
fever
outcomes were a
plus
composite of
tachycardia
maternal
is
sepsis
one of
death
them.
in 6
Yeah.
weeks after delivery. Which
I mean, that's like what, I mean, based off of like what I'm doing right now, I would say that's not sepsis. Cause you can have a heart rate of over 120 in labor. That's really normal.
And do you know what they got a C-section, like, you know, a few got sections, right? Did they do, you know, prophylactic antibiotic?
They do whatever was the standard of care.
So they don't.
Those institutions.
Reported any supplement or anything? Because that's, like, you know, if you do a C-section, somebody in labor, you know, she's pushing, you don't give her prophylaxis, she could surely get signs of sepsis or whatever. And, you know, maybe give her some Azythro. Help with that, you know. Again, trying to extrapolate it to our own practice.
I mean, it also gets interesting, like if you have high HIV percentages, like those patients might be on trimethoprim sulfa prophylactically also.
Do they report that? Do they talk about HIV or?
Maybe in the supplements, but not in the main paper.
Yeah, the devil is always in the detail. I guess like once again. Was there was no editorial with this, correct? I don't think. Which is interesting, you know, usually when there is something that people think could change practice, you know, usually.
I think there was actually.
There was one?
By Jean Sheffield, who's that?
Oh, there was, okay, I remember. And what did she say?
I haven't looked.
I read it when it came out then, yeah, that's. I don't think she called for a change in US practice.
So the C-section rate was 14% in both groups, and 14% in both groups got prophylactic antibiotics.
14%. But that's much, much different than what we do. We have prophylaxis everywhere.
Sorry, no, like 14% of, what's that? No, like 14% of the total group, but I'm not, it doesn't say like what percent of the C-section patients got prophylactic antibiotics. So it just happens that they're,
Similar percentage.
yeah.
They got C-section and got prophylactic. I mean, in labor, why would you get prophylactic antibiotics? I guess if your group is strep,
GBS positive.
but they don't report that.
I mean, for me, the choreo rate makes like no sense. That's the biggest thing.
For me, it means
you
they
have to
probably
be,
just
you have
weren't
to be
checking.
careful with antibiotics, because.
Oh, don't. Alan Tita answer my text. Surprised me too. I think a couple of things, low inductions, shorter labors, different populations. We monitor closely for misdiagnosis. Hope it helps.
Yes. So
Still didn't, I mean, that's impossible.
98% of patients who had a C-section got prophylactic antibiotics.
I mean, it would have been nice to see like a per
98%.
protocol analysis as well.
That's,
They also imputed a lot of data.
So yes.
I forget what percentage of it they had to impute, but
Resistant patterns are needed. Universally recommend. That's what Jean Sheffield said. Concern about resistance. But he's arguing, Tita is arguing that one dose shouldn't do that. Shouldn't change resistance, because there's like some previous like studies looking at, although small, looking at carrier rates after administration of one. I think that's what he writes in his paper.
you know, to me, a trial like this brings, like, you know, the larger question, labor, you know, like we've seen this morning, you know, can be dangerous, it can be associated with infect, like, you know, vagina is full of bacteria, they use sterile, whatever. So, you know, and you can still, especially in low and middle income country, have bad outcomes. But I'm just not convinced by that low cure rates.
Weren't like antibiotics regardless of GBS given in preterm labor back in the day?
Yeah, they're like 15 plus randomized studies for preterm labor. Drove me nuts because each one of them used different antibiotics, different doses, crazy, different lengths. And there's a Cochrane, and yeah, that because, you know, we use them for prom, but we don't use it for preterm labor because they were insignificant. But there were many, you know, 30 years. Yeah, that's a good.
What's the rate of neonatal sepsis here? Is it like much lower than?
Dr. Roman looked at this when they switched the diagnosis over. I just had her paper pulled up.
I'm just thinking if it's like dramatically lower, that it may not be worthwhile, but if it's similar.
So I would say is that these low-income countries are working to change practice, because I asked if they change practice anywhere. They're working, interesting. I've had questions. We are engaging with WHO. We should invite him to give proper answers.
Really should.
So Dr. Roman did a review of like our Jefferson data from 2013 to 2017. And that is when they like switched over between like isolated maternal fever versus triple I and then like placental confirmed choreo. And of that population, I mean, it was less than 200 women, like moms, and only one baby, so 0.2% had culture positive sepsis. Because right now, like our standard protocol is like they observe for 12 hours, they treat based on certain parameters, but like many of those babies don't actually have culture proven sepsis.
So, and you would think, if it's really efficacious that the babies should do better, because, if the mother,
Except for the larger C-section studies that are the indication for us using azithromycin, there is no fetal benefit. It's
Yeah,
all
it's maternal.
maternal.
right. That's, yeah, okay. What I'm saying, going back to what Katie was saying before, did anything else except for sepsis was better in the mom?
I mean, there are a number of infectious ones where they were.
Yeah, endometritis.
Which one?
Endometritis, wound infection. Used. Readmission rate.
I mean, if I had to guess, I would guess that they just weren't checking temperatures during delivery.
They have a temperature protocol.
But like that is their primary outcome. So I don't,
I think it's after, but I'm not sure.
They're finding a lot of it based off of like chart review. It's not like I don't think part of their protocol was like checking temperature every 6 hours.
The protocol for delivery was during admission, the following time points, at least every 4 hours during labor, as soon as possible after delivery, every 4 to 8 hours until discharge, and then before discharge. So
And what was their adherence to the protocol?
it just says they just present their like treatment adherence to the azithro and let's see.
Good review, maybe more questions and answers again.
yes.
Again, I tell you guys, these days I have more questions for everything than answers. When I was in your shoes, we never gave antibiotics to C-sections to anyone unless they had a fever. So I could see, now we're resisting this, quote unquote. It makes less sense that there are issues with this trial, even that the PI acknowledges. But I could see, studying more. And I don't know if it's time to switch to vaginal progesterone, but that's amazing. Are we done with this?
Other questions?
Rupsha, are you on? Can you hear us?
She's seeing patients.
So the issue about the vaginal progesterone, which we put on the agenda, is that, as you know, the FDA, took away 17P. SMFM came out with a statement which has been circulated, basically say don't use 17P. I think we're okay with that, and but then kind of put a question on the issue: should you even use vaginal progesterone for somebody with a history of preterm birth, which we are doing now. I was hoping that Rupsha was going to present a couple of slides because I had the slides, but I didn't bring them because I thought she had them.
Patients
Say it again?
we have a couple of patients last week who were like previously on HP and they're requesting it again.
Mhm.
So we tried to prescribe it, but Stephanie is saying that it's like not available anymore.
Mhm.
So should we stop offering it to those patients? Obviously, like patients who have never been on anything will offer only vaginal progesterone. But for the ones with a history of being on 7-HP, we should stop offering it to them as well.
I think that's what I would do also based on what the SMFM says. I think that SMFM and others would come, and ACOG, et cetera, would come up with newer bulletins and whatever soon. Yeah, and again, it's kind of what we talked about today, with breastfeeding and HIV, it's a discussion, we understand, you think it may work for you, whatever. But even based on Rupcha's meta-analysis, the hydroprogesterone, if anything, worked better, than 17p. So I think we can be reassuring on that side. Here you are.
Sorry, did I miss the whole discussion?
Yeah, we're pretty much done. No. We just started 30 seconds ago. We didn't miss anything. I kind of gave a little bit of a background, and Neel rightly, smartly so, say that, those that have been on 17p in the past, and you're actually one of them, and who requested, we should probably say that unfortunately it's not really available, and we would offer vaginal progesterone. That's all we have discussed.
Okay, yeah, I agree with that. And I just wanted to, start off just with summarizing the two different statements that came out. ACOG does not recommend 17p period, 17-OHPC period. They suggested specifically for singletons with prior spontaneous preterm birth. This is a new table that was an update to they had a new guidance actually in 2021. And then this is an additional update on that one. So for vaginal progesterone, they said only consider for short cervix versus cerclage. And similarly for a short cervix with prior preterm birth, they say consider cerclage versus vaginal progesterone. Although it's interesting that it says if not already on progesterone supplementation, which they say that the patient shouldn't already be on regardless. So that's the ACOG statement. SMFM gave an update and they specifically discouraged the continued provision of 17-OHPC. They cited, as did the FDA, no evidence that stopping 17p would be harmful. And so they're not saying, well, if you're on it, continue it for the rest of pregnancy. They're just saying that you should stop it. It's being withdrawn. It should not continue to be offered. And we can talk about what we want to do in a minute. I just want to make sure everyone knows what the statements are. And I'm happy to email out the links if you didn't see them already. They comment on the mixed evidence regarding the benefit of vaginal progesterone in those with a prior preterm birth and a normal cervical length, citing meta-analyses that have found benefit in population of patients with spontaneous preterm birth. The Romero analysis limited to a couple of large low risk for bias trials that did not find benefit for those with prior preterm birth and a normal cervical length. But given the mixed data, they said to counsel on the use of vaginal progesterone for prevention of recurrent preterm birth, taking into consideration patient-specific risk factors. They didn't really say what you're supposed to do with those risk factors, but basically they highlight what are the risk factors for increased risk of preterm birth, early preterm birth, including early gestational age of prior preterm birth, number of prior spontaneous preterm births, the most recent birth outcome. So if you've had if your most recent delivery was a term delivery, that's a lower risk than if your most recent delivery was a preterm delivery. And patients' prior experience with progestin therapy. They specifically also say for short cervix, vaginal progesterone or cerclage, saying that the added benefit of progesterone with cerclage is not known, which I'll provide some data on that, that was provided on oral and SMFM already. So this was the Romero, this is just a summary of the Romero analysis. So they did a meta-analysis of randomized trials, specifically looking at patients with a prior spontaneous preterm
I want to add something.
Sorry?
Can you go back to the slide before?
Oh, sure, yeah.
I think it says at the bottom, added benefit of vaginal progesterone with cerclage is unknown. And then they also say added benefit of cerclage after vaginal progesterone is unknown as well, in those patients that have a short cervix, which again is, I think, interesting too, looking at it the other way around, because we have patients with a history of preterm birth that are gonna be on progesterone, whether or not their cervix then is short, they're gonna be offered a cerclage. So I mean, they seem like they were pretty strong on the fact that in patients with a short cervix, equally effective. I know that that's an indirect meta-analysis, but it's interesting.
Yeah, it is an indirect meta-analysis. I think just by definition, it can't be a very strong recommendation when your data is an indirect meta-analysis, but that's just me.
Do you have any slides on the indirect meta-analysis?
I did not pull those slides.
Let me, for the fellows, let me just spend a minute on that. So Romero and Cano years ago came out with, and others maybe, with a meta-analysis that looked at randomized studies of vaginal progesterone for short cervix versus placebo or no control, and randomized studies of cerclage, you know, same patients, basically, singleton short cervix, cerclage, no cerclage. Different trials, right? The ones with progesterone, the very few, if any, cerclages, the one with progesterone, a few, many cerclage. And then put them together and say, look, you know, the results of preterm birth and stuff is the same. Since I don't like letter to the editor, I never did send a letter, but it's been burning me for a long, long time. If you look, as I have, because some of those trials we did, and you know, are very famous, should review them. The demographics are very different. There are a lot more Blacks in the cerclage group. There are more preterm births. The preterm births are earlier. Gestational age of short cervix is earlier. The cervical length is shorter. So if you do that, actually you could conclude, no, if you adjust for demographics, cerclage work better, but it's really apple and oranges, you know. It's like if we're saying, you know, Alan Tita does something or erythromycin versus placebo, somebody tomorrow does ceftriaxone versus placebo. Those patients are all, I don't know, you know, much higher risk for sepsis, and then you compare azythromycin from one trial to ceftriaxone. Like, but somehow that say it again?
So you've basically eliminated the randomization.
Right, you know, you're looking at
it's not
completely different populations. Yeah.
So it's not the same or even close to the level of evidence of a meta-analysis where you have, you know, participants are randomized to each group and then you're combining data, but it's still randomized data. You still have people who are, whatever the difference is in baseline characteristics between trials, it will still be distributed evenly in your combination data. Whereas an indirect meta-analysis, which is not an IPD meta-analysis, so it's not using individual patient data. It's just comparing two different groups. So it's the same as observational, essentially. You don't have any kind of benefit of randomization. So that's what I meant when I said the quality of evidence. You can't have a strong recommendation based on that quality of evidence.
I just think it's interesting because, you know, SMFM is saying you can offer both. Now, if centers are not going to be doing vaginal progesterone and you have a patient that comes with a history of preterm birth that has a short cervix and you're offering them vaginal progesterone or cerclage, I feel like they're always going to take vaginal progesterone because they don't want to have a surgery. It's so easy, like, you know what I mean? And so I think
and that's what Romero has been saying at international meetings for 10 years.
Really, yeah. It's wild.
Based on that indirect method. But go for it, then.
I'm sorry, just give me 1 second. I just have to respond to this. So this was the Romero meta-analysis. It's looking specifically at population of prior spontaneous preterm birth, which overall the meta-analysis did find benefit of vaginal progesterone versus placebo. But when they limited it to trials that were low risk for bias, they did not find that benefit persisted. There's some limitations to that. So, and Dr. Bragella prepared the slide here, which summarizes it well. So the O'Brien study, which was one of the largest studies, and it was here in the US, it excluded those with short cervical length. I think that's not so much an issue because as we know, we do recommend progestin. Well, we recommend progestin and cerclage, and I'll go into that in a second. And they also found that there was a decrease incidence of short cervical length with progestin therapy, and a decreased rate of cervical shortening. And so that goes into, you know, how you consider, you know, vaginal progesterone or not starting it until someone develops a short cervix versus if it is actually reducing your rate of developing a short cervix. The Norman trial found that there was improved neonatal outcomes with vaginal progesterone, and the Crowther study, which was a third trial that they included, did not take into consideration cervical length. The UK has for some time now been recommending vaginal progesterone for the prevention of recurrent preterm birth. They never recommended 17-OHPC, so that was not an issue. But they specifically noted that subgroup analyses for of trials for patients who had a prior spontaneous preterm birth and for those with a short cervix, and both had an improved benefit. And so they have long recommended vaginal progesterone for the prevention of recurrent spontaneous preterm birth. This was, this was the meta-analysis that was done by NICE, which is like the National Institute for Clinical Excellence. And they do, you know, a number of meta-analyses to guide their clinical guidelines. So they looked at this, and this is similar to the Romero meta-analysis for patients with prior spontaneous preterm birth. They looked at 5 randomized trials, which you can see overall, all the trials found benefit, whether some of them were statistically significant versus not, but you can see that, you know, the odds ratio is, or the relative risk rather, is, you know, kind of similar across the board. For prevention of preterm birth less than 34 weeks. There was a network meta-analysis that was done by Jarde et al. In 2019, which also looked at, this looked at the subgroup of patients with a prior preterm birth and found that vaginal progesterone was effective in reducing the risk of recurrent preterm birth less than 37 and less than 34 weeks. There's 17p data here. Again, this was in 2019, so it does not take into consideration prolong. This was the meta-analysis that we did comparing vaginal progesterone and 17p, which for all studies combined, we found that there was benefit of superiority of vaginal progesterone over 17p in prevention of preterm birth less than 34 and 37 weeks. Although similarly, when you limited it to the high quality trials, that was no longer significant, although the sample size was much smaller because of the limited number of large high quality trials. Talking quickly about progestin plus cerclage. So this is the oral, this is from the oral that was presented at SMFM. This is observational data. So this is a retrospective study looking at patients with cerclage placed for any indication with and without prior preterm birth, and to see if progestin along with those who had progestin along with cerclage versus cerclage alone, and look at outcomes of preterm birth. Across the board, there was a significant, these are statistically significant, after adjusting for confounders, reduced rate of very early and just regular old preterm birth with a combination of progestin with cerclage compared to cerclage alone. There's increased latency to delivery as well. And in looking at subgroups, you can see that overall, you know, there was a reduced rate of preterm birth less than 37 weeks with vaginal progesterone specifically compared to no progestin with cerclage. There was a reduced risk of preterm birth less than 37 weeks. This was most noted in those with ultrasound and exam indicated cerclage, and not statistically significant, and evenly not even in the same range for those with history indicated cerclage. So I think that's the only setting where I would wonder, you know, how beneficial the additional progestin is, but that's another bag of worms because this was retrospective. So like what someone, from 12 different centers. So what someone decides is a history indicated cerclage, it wasn't something that was consistently controlled for, that was controlled for at all. And it's something that I think has probably the most variability in practice. So I think it's hard to draw conclusions about that. It was no longer statistically significant in the subgroup with prior preterm birth, but again, you can see the odds ratio is kind of similar down the road. And this is same thing for less than 34 weeks, same findings. So
Just to clarify, that's progesterone after placement of cerclage.
That's a good question. So it was anyone who continued progesterone after cerclage was placed. Some of them started it, like half of them started it before and continued it, and half of them had progesterone started after the cerclage was placed. But we looked at it all together. Does that make sense?
Yeah, I think what would be interesting, again, I don't know if there's data, like the data's here on it is limited strictly to the patients that had been progesterone before, then got cerclage, let's say for short cervix indication, let's say ultrasound indicated, and whether there's benefit in that group would be interesting.
Yeah, the numbers just get really small
Yeah.
when you start parsing it out by that, because I thought about doing looking at ultrasound indicated in prior versus no prior, but it was like it was like 20, in a group. I didn't even do the analysis because it's just a small number, which I guess I could, but it just becomes small once you're dividing it up that much. These were the subgroup numbers, so you can see it here. And we had a much larger number of people in the progestin versus the no progestin group. So most of the patients in this cohort with a cerclage did have progestin therapy. And so once you're getting into 60 patients with an ultrasound indicated cerclage who were not on progestin therapy, and then you start splitting that up further, it's just really small.
As you know, people know Moti is interested in vaginal progesterone, bless you. If used even before 16 weeks, for possibly, this indication of preventing a recurrent, for which there's not much data by your initial review. So the question, and maybe
because the recurrent pregnancy loss patients are going to be stopping the progesterone, not continuing until 36 weeks or not. We may have found something that's up to 20 weeks, but really no one from 12 to 36. That's like the hard.
So the question basically is, what are we going to do this afternoon, in clinic when somebody comes with a prior spontaneous preterm birth? And Rupsha, you want to comment on that?
Yeah, I mean, I think so. My personal thought is for anyone on 17P, I would suggest changing them to vaginal progesterone. For any new patient, I would counsel them on vaginal progesterone for prevention of recurrence preterm birth. And I agree that there is mixed data. I would not offer it as ACOG suggested. I would offer it, and I would, like, for me, the patient specific factors certainly play into it. They had, if they were on progesterone therapy in the past, if they have a history of cervical insufficiency or short cervix or very early preterm birth, those are the patients that are at higher risk. Again, that's just like clinical judgment based. There aren't studies looking at these specific subgroups to say, aside from short cervix, to say that this specific subgroup would benefit and the specific subgroup would not. But those are the patients that, for me personally, I would more strongly counsel on progestin use. And I would certainly still do cervical link screening. I would still recommend combination. So starting progestin, and then if they have a short cervix, doing cerclage with progestin. If they decline progestin and have a short cervix, I would do cerclage with progestin.
And then, so then not offering 17-OHP like at all.
Yeah.
And I think we're a little lucky here because like I think ACOG pretty much says no, but FFM says shared decision making, so at least we have that support of using that as a way to continue our practice here.
A quick editorial comment. It's amazing, and that's why I beg you guys, later on, have an open mind. Because, I lived in 2003. If you didn't put people on 17p, you were a criminal. They were FDA, NIH, you name it. People were looking into states that didn't reimburse it, and that was illegal. And if you didn't have over 80% compliance, and it was discriminatory, and it was a racial issue as well, and coverage and cost, and really it was just finally we have something, it works. And to be here, I can tell you, for me, it's a little bit makes me uncomfortable, to have lived like, now we're not going to give it to anyone, forget it, that's what, and back then it's like, if you don't give it, I'm going to fire you. It's just,
So just to be clear, if they're on 17 OHP now, we should talk to them about transitioning to the vaginal.
I mean, that's what their societies are saying. But what I'm saying outside of society is that I just know that in your clinical practice, which hopefully will be long and happy, you will do stuff that then you'll change, and then maybe you'll change again. And just, to me, it's a little bit uncomfortable. Like I went back, I wrote an article in 2012 with Dr. Iams, who was my, just the two of us, care of women with preterm birth. And I looked at it yesterday because I'm trying to write an article on these issues. And I'm like, oh my God, like, 17p, please, 17p. And, it's just.
I feel like it's not the only intervention.
And
right
just
there.
to,
Swing
Yeah,
it.
it's one of many. Yeah.
Wild.
and I think just
I think
the other
it's
thing for 17p, to highlight is, I guess, this is all coming out because the FDA withdrew it from the market. And so which sounds like a bigger deal, I think, than it is if you recognize how much we do without any FDA approval, period. So vaginal progesterone crinone, they applied for FDA approval for the indication of short cervix, and the FDA didn't approve it at all. So vaginal progesterone has never been FDA approved for the indication of short cervix. They declined to approve it for that indication. And we use it all the time. It's part of a national guideline. Aspirin is not FDA approved for prevention of preeclampsia, and it's part of the USPSTF guidelines. Misoprostol has like a black box warning regarding to use in pregnancy and on labor and delivery. It is a standard of care therapy. So it's just, to me, it's like a little frustrating that this is coming out, following the FDA decision. None of this data is new. Nothing that they're talking about is new. This was all available immediately after Prolong. Multiple analyses were done by the FDA after Prolong. But it seems like this big deal that the FDA has withdrawn this medication. And I just want to highlight that we do a lot of things without FDA approval because of either strong evidence in favor that didn't meet XYZ FDA criteria. For vaginal progesterone, it was that they only looked at data in the US and it wasn't significant in that subgroup. Or because no one applied for it, or because the evidence is mixed and we as physicians make a decision taking a specific patient into consideration for off-label use of a medication without counting on the FDA to tell us that's okay or not. So just to, emphasize what Vince said about keeping an open mind, like this doesn't mean that there's no benefit in progestin therapy, that that there's no benefit in 17-OHPC that could be beneficial for specific indications for specific patients. There was a large trial that found benefit with 17-OHPC, and you can't pretend that didn't happen. And in our retrospective work, you can see, this was looking, again, this is this retrospective study at cerclage in patients who had progestin versus not. And you can see that those with vaginal progesterone or 17p, both of them had increased latency to delivery compared to no progestin alone. And even in our subgroup analyses, This is for less than 37, this is less than, this is a typo, this should be less than 34. You know, the trend is the same, so I just want to put it out there to make sure that you kind of recognize the politics and other things that go into these, and keep in mind always thinking about what is the actual evidence for or against something.
Do you think that people, let's say uninsured, prior use of 17-OHP, have the money, will go to like compound pharmacies and still use it? Even though I know that the compound was removed as a recommendation, but like, again, I'm not evident, like, I'm just thinking like Upper East Side patients that I used to deal with in New York. I can't see them not wanting to go to find a way to get it and.
I
use
think
it.
they certainly could. I think our population is less commonly that tied to it.
Yeah.
Maybe Katie in the Upper West Side of Philadelphia will know.
I could give myself 17 OHP.
And the other thing with it is.
Yeah, I'd be
The
pleased to-
vaginal progesterone, most insurances do approve vaginal progesterone for any kind of preterm birth prevention indication. And that hasn't been a problem for us getting that covered by either private or Medicaid. I don't know if they will continue to cover compounded or 17-OHPC for that, like, you know. Probably right now you could continue to get it because it would continue to be covered because they haven't changed their policy yet, but that's just another thing to keep in mind. Because vaginal progesterone is available on the market for other indications, we can use it off-label, and insurance companies have recognized that it is used for the prevention of preterm birth, and so that as an indication, it's covered. 17-OHPC was only on the market for the indication of prevention of recurrent preterm birth. And so if it is off the market altogether, I don't know if a compounded formulation will be acceptable. Will be covered by insurance.
Well, that's a problem. The patients we had last week, Stephanie sent their prescription to a compounding pharmacy. They said they couldn't even compound it.
Oh, yeah?
Yeah,
Yeah, so it might just not be available. Was it to Booth one? Are they're just not making it anymore, maybe?
it wasn't Booth when it was Value Pharmacy.
Okay.
All right, humbling discussion. So I'll pass it on to Einstein, and you know that.
Well, I mean, did anyone disagree with what I said? Anyone just like make?
No, I mean, I looked at the faces around, that's why, but we had this.
Okay. Sorry.
But I mean, I think again, just focusing on that second meta-analysis of Romero and Conde on like just those with a long cervix. You know, that, because that's, you know, I was trying to look at like when the cervical lengths were done.
Yeah.
Because if you're saying it prevents the like in that O'Brien or whichever sub-analysis, if it prevents the occurrence of a short cervical length, and you're eliminating patients with a short cervical length, focusing those on a long cervix, then
Of course, it's not gonna work.
yeah. So,
Right.
so
That's the
then,
point
but
of
those
what
cervical
we're
lengths were done like, I looked into each one, like none of them were done, I think, as early as 16 weeks. So are we missing some of those patients? I'm just like speaking out
Yeah,
loud.
so the progesterone in the studies was also started later.
Yeah.
Often at 24 weeks. So, you know, the point is, if you have a prior spontaneous from birth and you take all of them together, and those on gestation, about 40% have a short cervix. And I think if you look at the data, I do agree, those are probably the ones that will benefit the most from vaginal progesterone. The issue is at 16 weeks or 14 weeks or whatever, the cervix is probably going to be normal. It's going to shorten at 20, 22, you know, 2 weeks. And if vaginal progesterone prevents those short cervix and therefore probably prevents those preterm births, that's why the idea, based on all of the groups, decided to still give vaginal progesterone. Also because a lot of those trials either started progesterone late. O'Brien was 90 milligrams. The other one was 100 milligrams. They started after 20 weeks. it's, and we do.
Yeah,
think
it's like
we're short circuit.
we're using it for a broad use, for a broad category, because once you start splicing down the data, we don't have good data on these small subgroups and on when you started it and on exactly when they were measuring cervical length. And so then it becomes harder and harder to draw conclusions from those splices of data.
And another point I wanna make, this is gonna change again.
Yep.
I'll tell you, the dose is gonna change, when we start, it's gonna change, cervical is gonna change. Maybe we will change, you know, we will come up with the cervical softness that we'll do at 12 weeks and we'll give progesterone 12 weeks like you wanna do, like. This is, you know, that's what we're gonna do, this, decide April 13th, whatever is today. And, you know, we need to be open. Like, I think SMFM and ACOG will come up with statements and.
I think there'll still continue to be research also on 17P. I don't know if Dr. Carides will continue his work on 17P, but you know, one thing that his studies showed, again, not new information, this is from a while ago, but the serum levels of 17P in the third trimester were correlated with the rate of preterm birth. And one thing that he wanted to look at was difference in dosing or timing of dosing, because if, you know, someone's not at an adequate serum level, is that the reason that you're having drug failure? Is this, you know, there's like a single dose used for everyone. There weren't dose comparison studies done. So was there a problem with the dose selection to begin with? And so I know that they did a study on 500 milligrams of 17P. I don't know if that's been published or if that's ongoing, but you know, like Dr. Bergala said, I don't think it's going anywhere. And again, I just wanted to highlight that data, there's nothing that changed with the evidence in the past year. So what we had talked about last year, nothing changed. It's that this drug was not available in the market for any other reason. And so it is physically not going to be available to prescribe anymore.
Is somebody sharing, somebody wants to do scans?
It's just, I think it's ruptures.
Oh, it's ruptures, okay. Any other clinical issues to bring up or patients?
I had, oh, you know what, I wanted to mention, I don't know if we did outpatient already, the patient who presented an OBCC who has had, who had corrected, imperforant anus as a child and was recommended C-sections to begin with, and is, I think, on her third or fourth C-section now. The main reason I wanted her to have a consult was that she had, at her prior delivery, she was scheduled at 39 weeks. She prommed at 37 or 38 weeks and had an unscheduled C-section. It was delayed till the next morning. It sounded like a significant surgery. There's a lot of adhesions. They went in slowly, etc. So I think for whoever is seeing her for consult, I wanted to address, you know, timing her C-section at least at 38 weeks, if not earlier. I would have to, I don't remember what her gestational age was at prom, but just given the extent of her prior surgeries, like is not someone that you want to be doing in the middle of the night because they come in, you know, ruptured and laboring. So
An indication for.
I don't think it's an official indication, but we could make it an indication, right?
Like, is that something we get dinged on?
Say it again?
Is that something we get like dinged on? Like, there's no like actual indication for an earlier than 39-week C-section.
So I think, yes, so I think we need to be specific and, you know, the indication doesn't have to be, you know, one of the listed ones, as long as we really think it's an indication. So as long as we're clear, everybody knows, then we're not gonna get there.
We want to do 37 or 38, because we're seeing her for consult next Tuesday, I think.
I mean, I think 38 would be good. I think it's harder to, you know, the risks for neonate go up at 37 weeks and it is a C-section. I think it's also harder to justify. But you know, I'm open to other people's thoughts as well. That was just my main thought when I saw her.
When her last prom was, the last prom was at, you know, 37 and 6, and I think 38 is fine.
It was definitely not before 37 weeks, and it was definitely before 39 weeks, so it was sometime. 37 or 38 weeks,
You could argue if it was to do it earlier than when her prior,
Right, exactly.
right.
It would be 37 weeks.
was it 37.6? Is that what it was?
No, I'm just saying, if it is
Oh.
37.6, then I could be okay with 38.0, but if it was 37.0, then I would argue for 37.0 this time.
Yeah. I can't remember her name now. I was gonna look it up, but
Look it up right now.
Yeah.
It's Camelin Morales Barrios.
and she's fine with whatever. I think she also wants her tubes tied.
She does on the tube side, yeah.
Very concerned about, the risks that she's taking with every subsequent surgery.
She prommed at 37.6.
Alright, 38.0.
38.0.
This will be her,
Oh, well, I'm saying you could do like 37.5, 37.
her second section.
I know, it's.
Great. Anything else? I know it's a beautiful day outside.
I think eventually we should talk about TXA and kind of figure out how that's gonna, we're gonna continue giving it.
Yeah, absolutely. I think that's something we need to, we can.
I'm happy to do it for Journal Club.
Again?
I'm happy to do the article for Journal
Yeah,
Club. If
yeah.
people are okay waiting.
Yeah.
If you want to address it earlier.
Yeah, no. Let me know and we can put it on one of the future Thursdays.
Yeah, whatever, the third.
Second
Second.
Thursday of May.
May.
So we're going to make a. Yeah, the second Thursday of May, it's May 11th, it's research day.
Right, another time.
Some of you know well. It's coming up,
Really, it's a month.
friends. Yes,
Yeah, because fetal therapy is first and third, so fetal therapy is 4th and 18th.
yeah.
Okay.
11th.
Is this what day is it? Okay, got it. Okay, so
MFM meeting.
Right, I mean, it will be in research meeting all day.
Stephanie is writing on the chat. Yeah, we spoke about it. We're gonna try and switch to vaginal.
okay, so we're not doing.
Is there a question about how we're identifying the patients on 17P? So that we can follow up with them.
June, whoever's in June.
Patients told 17P last.
Lisa said Stephanie made a patient leave.
This only came out Friday, didn't it?
That's Friday, that's.
Swift.
Yeah, Stephanie, if you could just add me to it, I'll start calling the patients next week.
Thank you very much. Okay. Great meeting.
Good to see you, everyone. Sorry.
Hey, good to see you. Thanks for your help.
Let's look outside.
I know it's beautiful.
Yeah.
Like.